Welcome to the Advancing Surgical Care podcast, brought to you by ASCA, the Ambulatory Surgery Center Association. ASCA represents the interests of outpatient surgery centers of every specialty and provides advocacy and resources to assist them in providing safe, high-quality, cost-effective patient care. As with all of ASCA's communications, please check to make sure you are listening to or viewing our most up-to-date podcasts and announcements.
Hello and welcome to the Advancing Surgical Care podcast. I'm Bill Prentice, the CEO of the Ambulatory Surgery Center Association, or ASCA. On this episode, we'll be talking about electronic health records, or EHRs for short. And to bring this issue into focus in the ASC setting, I will be joined in a moment by Melissa Rice. Melissa is the administrator of the Loyola Ambulatory Surgery Center, a member of Trinity Health, located in Maywood, Illinois. Melissa is a seasoned clinical advisor and healthcare executive with over 15 years of experience leading ambulatory surgery centers and driving operational excellence. She actively participates on several ASCA committees, and just last week, Melissa was elected president of the Illinois Ambulatory Surgery Center Association. In addition, Melissa has firsthand experience with the adoption and integration of EHRs, and she's generously agreed to share her experience with us. But before I bring Melissa into the conversation, I want to set the table for our discussion by saying a few words about EHRs. To be clear, the list of promises associated with the EHRs is long and admirable, and ASCA, like most healthcare organizations, supports their adoption under the right circumstances, and I'll have more to say about those circumstances. It's been said that EHRs have the potential to vastly improve healthcare by enabling seamless information sharing among providers and payers, empowering patients with their complete medical histories, and improving both clinical and administrative efficiencies, and further advancing medical research and data analytics. And to be fair, a strong case can be made for each of those claims. Yet a number of obstacles remain in the way of this digital revolution in healthcare. For starters, old habits die hard, and there will always be some resistance to change. We know also that new technologies can often have steep learning curves and long runways of adoption. There are also substantial costs, both in terms of cash outlay as well as the allocation of staff time, and this is especially true for smaller independent ASCs that operate on tight margins and have smaller teams that are already stretched to the limit. Finally, as with any technology, there are competing products and systems that lack a unifying set of standards and specifications. And until that day comes, it's unlikely that EHRs can fully live up to the promise of instantaneous information sharing amongst providers, patients, and payers. Yet with all those roadblocks in the way, more and more providers are still forging ahead with the EHRs, finding the time and investment can also and often does pay off for both the provider and the patient. Melissa is one such pioneer, and I'm pleased to have her with me today on the podcast. So, Melissa, welcome.
Thank you. Happy to be here.
Great. So, a moment ago, I mentioned that you were elected president of the Illinois Ambulatory Surgery Center last week, and I want to personally congratulate you and thank you for your service. Before we talk about EHRs, can you take a moment to share with us a little bit about your career and the path you've traveled to get to this leadership role?
Thank you. Yes, I have started out in the clinical role in the beginning of my career, which was amazing, being able to assist the providers during all different specialty surgeries. And my extreme want to learn more about not only healthcare, but ASC specifically, has allowed me to put myself in different positions and different roles throughout my career and brought me here to be able to be a leader in healthcare and ultimately a CEO for a surgery center.
That's amazing. Well, Melissa, we need to take a short pause to hear a few words from our podcast sponsor. Please stand by and we'll be right back.
This recording of the Ambulatory Surgery Center Association is being brought to you by Surgery Partners, a leading operator of surgical facilities and ancillary services with more than 200 locations in 33 states. Surgery Partners offers multiple types of healthcare services that deliver high-quality healthcare in a convenient and cost-effective manner. To learn more, visit surgerypartners.com.
Melissa, there's a lot to unpack when it comes to talking about implementing EHRs. Maybe you could start by talking about your expectations, your experience with soliciting proposals, and whether the process and results ultimately met your expectations. And in a moment, we can get to some of the details like expense, training, and adoption by staff and patients.
I would say, personally, when I have looked at adopting EHR, because like you said, old habits die hard, and most places want to stay on paper because it's there, it's right in front of you, you could touch it, and that's what they're used to. We definitely went out in the market and looked at all the different players that were specific to ambulatory surgery centers, and there are a lot of great ones out there. We took at least 2 years to review and process all of the information. We were able to then go out and look at the centers that were already adopting some of these places and look at what worked for us, whether it be the way that the patient were able to see everything immediately, or if it was what was cloud-based, what wasn't cloud-based, how things were allowed for the providers to have access to versus non-providers. And then ultimately it did come down to finances and how well it worked for us, our specific ASC.
And when you say who's the we that worked with you in terms of doing that evaluation and looking at those proposals?
So on the ground evaluation, I made sure that I had my key point players in the game. So I got a champion physician to be a part of it that really understood where we were headed in regards to EHR. So they were part of the technology wave that was coming. I also made sure that my head clinical director, charge nurse, director of nursing, whatever they're called in the center, was a part of it as well, because there's a lot of aspects to compliance and all that type of stuff that we needed to make sure that we were hitting. And then I also made sure that we had an anesthesia provider that was also part of it, because once you flip that over, they need to also understand that. So as I personally gathered all the information, I was able to present that, whether it just be a personal meeting or we were able to do virtual meetings or have them on site.
Fascinating. And so you talked about clinical leaders. Let's talk about your facility staff and the physicians and how they responded to these new systems. Did you meet any resistance? What was the learning curve like? And how would you say the staff thinks about electronic health records today versus maybe how they felt when the first day you introduced it to them?
So upfront, 100% resistance across the board. They are like, absolutely not. Why change something? And I think that's a lot in healthcare that people look at it from that aspect. Once we started to show them how a lot of it was going to help their charting and was going to take them away from looking at the paper to actually focus on direct patient care, it was a kind of an aha moment for them. It also showed them that there are some things like charting by exception. So when one person puts one set of information in, even though it's needed in other areas, it's already there for them. So that also was something. We're not doing redundant paperwork as well. The learning curve. It depends what type of array and aspect you have of staff. I ultimately was able to adopt a center that had a lot of the legacy people there. So the learning curve was very high. But then I also had some newer staff there that was really excited about teaching and helping out, and whether it be the providers, the residents, because I'm in a teaching facility and stuff. So I had a mix of everything, so it worked. Today, how they feel about it, they absolutely adore it. The first 2 months were horrific. There was a lot of challenges, a lot of mistakes. But ultimately, I told them, you get the important stuff in first. We could always go back and look back at it. So having that mindset of them understanding, getting the signatures, getting the times, getting the people in there is okay. Then we can take a step back the next day and look at what did we miss? How do we change things? Is it a change of the way that we put the chart together, or is it something that we need to eliminate or collaborate on? So having that mindset as a leader, but also being there and in the thick with your team really helped adopt. And that 2 months go by really, really fast.
So any distinction between that adoption period with your colleagues versus the physicians in the facility, particularly by owners versus non-owners, any kind of complications there?
So my presence base, I'm in a teaching facility, so we're all employees together. So it really is not. But yes, there was a very big difference from physician-owned to non-physician-owned and providers. The non-owned ones could have cared less. They didn't care. They didn't understand that there was a financial impact up front, but it was also then going to play itself out and be great. So there was a lot more resistance with them. And they also weren't there as much either. So it was, why do I have to do this? I only come here once a month. Why can't I do this? So there was a little bit of a learning process to that, but they came around and it ultimately was adopted.
Great. So I'm also eager to learn how your EHRs are accessed by patients and other external sources and providers at all. What can you tell us about that?
Yeah, like I said, all the players for these EHRs in the market now have adopted a cloud-based access for majority of their EHR aspect. Some of them still have some scheduling and billing stuff that is specific to something that you do have to have ultimately put on your computer. So for that aspect of it being cloud-based, it's great. We can be out on vacation somewhere and be like, hey, you need to sign this for whatever reason they didn't get to it. Look at some lab work that they needed to look at or specimens. And it's great because they could have access to it. So that stress and having that ultimately on your plate, making sure you get everything done is gone. In regards to patients, a lot of the EHRs out there do have cloud-based medical record access systems for them where they can actually put their own personal information in and keep up with it as well. So if it does change, they can, access that as well. So it's been really great to be able to have that direct communication with the patients because that also makes them comfortable because they're able to see it and it's not just what you put on paper.
Got it. So you've kind of been talking about a lot of this in some fashion, but I'm going to ask it kind of a really pointed way. Give examples of how the EHR has benefited your facility, staff, and patients qualitatively and quantitatively.
I would say, less paper. I feel like we all have that. Like I said earlier, it's charting by exception in a sense because it allows the areas of the chart that free flow through each of the sections, whether it be in the pre-op aspect of before your care, during your care, and then after care. Once you put that information, and I'll just give an example, height and weight, Everyone has to acknowledge it in every aspect of it. Once it's put in once, it goes across the board.
Got it.
All you're doing is then acknowledging it again. You say, you know what, this is, you're that information. It has reduced the amount of paperwork, like I said, but it also has reduced the hours that our staff has to go through the paperwork. A lot of these EHRs have automation in regards to the chart aspect so that you already see like what has been done and what hasn't been done. So I don't have to spend 2 nurses' salaries 3 hours a week to then do chart audits. It's already done. It's already automated for you. So from a financial aspect, sure, up front, it could look a little mundane, but it also then saves you time in the back end.
That's great. So as I mentioned at the outset, there's been a faster uptake of EHRs in hospitals and physician offices in comparison to surgery centers for a number of reasons that I outlined earlier. So at the national level, we either need to have a hat in one hand asking for financial support to allow surgery centers to be able to afford buying this technology in many instances, or we have to push back against attempts to force mandates without due consideration of both the cost and lack of standards that we currently have. So part of our challenge in this scenario, I think, is being able to demonstrate how EHRs are ultimately beneficial to patients and to Medicare in substantial ways. Do you think there's an opportunity to use your experience and that of others to make that case that it's worth it?
Absolutely. I think having a couple of your patients that can see both sides of it and see, I think that all these EHR companies are also looking at this in a back spectrum. I'm going to say the ugly word that EHRs and the ASC don't like to hear, but Epic is the biggest player out there in regards to healthcare and having it accessible to patients across all providers, across all different types of state lines and stuff. So I think that a lot of us are looking at it for how can we also partner in that aspect so we all have the same information. And I think once we can get to there, having leaders like us, as well as yourself, Bill, being able to play that case, I think the larger aspect of, like you said, being able to have the government come in and help subsidize some of this cost for us, I think it's going to be a good thing.
Yeah, because I know one of the long-standing concerns that has existed in the ASC community, because there are a lot of horror stories from years gone by of the surgery centers buying the wrong system and realizing they've wasted hundreds of thousands of dollars on a system that ended up not really fitting them and not really being interoperable, couldn't speak with other systems. Do you feel more confident that we're getting there, even though we don't have like a government-approved standard that interoperability is in sight?
No, I think I do. I think the more that we use our voices and talk back to the vendors and let them know what works and what doesn't work, unfortunately, I think people get into a situation where the financial aspect is the number one key player where it shouldn't. We should look at how is it going to service our patients first and foremost. And then secondly, how is it going to make sure that we take away the mundane aspect of having to chart physically and like really focus back on the direct patient care. A lot of the vendors have been listening to a lot of us, our leaders, and understand the aspect. But I think we keep pushing harder and harder. I think we are headed that way.
That's very good to hear. Well, Melissa, I want to thank you for taking the time to talk with me today and for sharing your experiences and insights. I also want to thank you again for all your contributions to ASCA and congratulate you one last time on your election as president of the Illinois Association. And I look forward to working with you in the years ahead.
Thank you very much. I appreciate it.
Now, before concluding, I'd like to acknowledge the support of our podcast sponsor, Surgery Partners, a leading operator of surgery facilities and ancillary services with more than 200 locations in 33 states. Surgery Partners offers multiple types of healthcare services that deliver high-quality healthcare in a convenient and cost-effective manner. To learn more, visit surgerypartners.com.